patient safety organizations, or PSOs. And so we'd like to have this be a conversation and kept at a high level. And joining me, as Dr. Antebi mentioned, is Kathy Wire. And so we're going to kind of tag team back and forth here. I'll kind of get started, and then Kathy will step in and explain a little bit about the legal side of patient safety organizations. And some of you have maybe never heard of a PSO before, or maybe you've read some recent publications that have been out around PSOs. But I think as our profession starts to look at the importance of quality and safety and improving the care in our communities, PSOs will begin to play a greater role in what we do as organizations. So let me see if I can get the slide to move forward here. So we're going to talk a little bit about who we are and what we do, and essentially how we do it, and how a PSO can support your organization and work towards taking a proactive role as opposed to being reactive when it comes to adverse events or unsafe conditions in your organizations. So the Center for Patient Safety, we are a private, non-for-profit organization. We've been working in healthcare since about 2005, and we work with hospitals, health systems, long-term care, physician practices, and EMS. And so we offer a number of different programs and projects and collaboratives with all these different providers, and one of which is our PSO services, which we'll talk about today. And so behind the scenes, like any organization, it takes a lot of people to make things happen, and an organization is only as good as the people that work there. So we're very fortunate to have a great team of patient safety experts and people that have dedicated their careers to improving the quality of healthcare and reducing harm that might be occurring. And so we have a wonderful team at the center. And unfortunately, we have two people left off on the slide, Jennifer Lutz and Diana, who are in the office and keep things running behind the scenes. So let's just jump right into a little bit of patient safety as a background and to kind of set up this conversation. And we unfortunately don't get a lot of education around patient safety when we go to paramedic school or throughout our formation in EMS education. And if we do get it, it's something that perhaps we might seek out, or something that we might acquire through working with a hospital or another person that's very knowledgeable in this. And there's two publications here that I'd like to have you maybe take a look at. And the first one is called To Err is Human. And this was a report that came out from the Institute of Medicine a number of years ago. And this report was really kind of the, or kind of laid the foundation or created the inertia for the patient safety movement in the hospital world. And what it talked about was the conditions that were attributing to poor outcomes or adverse events that were occurring in hospitals and health systems. And those are the things that we kind of hear about now with the hospital-acquired infections and falls and wrong-sided surgeries. And really, it was the impetus to make change and to create a safer experience for the patient, and to also help the providers and those people that work in hospitals, so they have a better system and approach and processes, as well as improved safety behaviors. Our profession, EMS, we had a similar publication come out a few years ago, the National EMS Culture of Safety. And this really talked about a lot of the gaps we have in our work and the opportunities where we need to kind of dig into patient safety and look at the areas where we can make improvements. And it identified a number of places where we could start. And it talked a lot about how patient safety has been studied well in EMS. There's not been a lot of research or resources allocated to this work. And so it's a hope that this will start to continue to drive that conversation and move forward. And certainly we've made progress with provider safety. And so we still have a distance to go with that, but patient safety, I feel, goes hand in hand with that piece of provider safety. And so we're excited about the attention patient safety is getting and the opportunities to share this important information. And one of the gaps is the data. We just don't have a way to gather information around the frequency of events. We don't have an opportunity to understand the harm levels that are reaching patients. And it's probably for a number of reasons, one of which is that oftentimes we don't have a way to share this information that's a way that we could put it out there so we wouldn't be fearful of litigation. Also, we typically don't want to share information that might affect our image or reputation as an organization. And so I think as you see our presentation today and hear from Kathy, you'll see that a PSO is a way that we can work collaboratively to share information and learn from each other. And likewise, there's a great opportunity to learn around what we call near misses. And just as you see in the picture of the iceberg, oftentimes when an event occurs in an organization, that's just kind of the tip of the iceberg. It's down below the water where those near misses are occurring, where we could really be proactive and take that information and knowledge and work towards preventing a future occurrence. Now, there is one study that we often share with our professionals, and that's a study that Dr. Hoyle did that you see here. And I think this study is important for several reasons. It brings awareness first to the fact that we know that harm is reaching patients. And second of all, this particular study also shows it's reaching a high risk population, and that's our pediatric population. And it also, I think, shares to us, whether we're leaders, providers, administrators, that when an adverse event occurs, it's really a cascading event. It affects a lot of people. It certainly affects the patient and family because they have to live with that event for the rest of their lives. But it also affects our providers. And I think that picture there of somebody just sitting there out in the middle of nowhere really shows that when an adverse event occurs, it's a lonely place. I mean, there's fear, there's anxiety, there's worry, there's anger, and so it's really time that we look for improved ways to prevent harm from reaching our patients. And so that's really what PSOs or patient safety organizations can bring to an organization, is a way to offer a way to share information and also move towards that prevention type of philosophy. And so I'm going to turn it over to Kathy, and as Dr. Antevy mentioned, Kathy is an attorney and has many years in healthcare, in risk management, and in other areas, and she really helps to articulate well how patient safety organizations can work for you and the benefit of participating with a PSO. So Kathy, I'll turn it over to you.
All righty, thank you, Lee. First of all, you may be asking, what is a PSO? And they are creatures of federal law in the sense that there is a statute I'll talk about in a minute that enables organizations to voluntarily become PSOs. We have to want to do it, and we work with voluntary participants. There's nothing mandatory about the program. So the PSO is an organization that collects data from participants. We study it, and we develop and support recommendations for safer care. Any provider licensed by a state can participate with a PSO. So in Missouri, we had a lot of interest from our EMS community, and so we were able to begin to interact with EMS, even though in a lot of areas EMS does not have other protections or interaction on the safety side. And then what's reported to the PSO? It can be medical errors, near misses, or unsafe conditions, which we define as, you see something that needs to be changed in order to be safer, it can be reported to us. Next slide. Lee?
Yeah, I'm sorry.
The next slide. Thank you. The specific law that we're dealing with is the Patient Safety and Quality Improvement Act of 2005. The citation is up there. If any of you want to look at more information about the act or the regulation that has followed it, you can get it on the website for the Agency for Healthcare Research and Quality. If you do a Google search for AHRQ, Patient Safety Organizations, their website comes up, and one page of that has links to all of the legal information about it. The law, back one. The law establishes a framework that encourages adverse event reporting, and it was acknowledging all of the things that Lee talked about, that people are afraid to report for any number of reasons, whether it's public shaming or liability issues. And so it tried to establish a way that people could report and yet not encounter those risks. It establishes a network of patient safety organizations with the anticipation that we would work together in order to aggregate data and work on solutions. And the focus is on sharing information so that we can learn and prevent. That's really the underlying purpose of the law. It is a federal law and a federal regulation, which means that it has the power to supersede any less protective or less involved state law. And that's becoming clear as time goes by. Courts are actually enforcing that. We wanted the safe environment, and I'm going to talk a little bit later about what the protections look like, but essentially information that is gathered as part of your process for reporting to a PSO is protected from discovery, subpoena, disclosure under almost any circumstances. And the other intent was to have a voluntary approach to prevention and reporting. The law was initially developed during a time when there was a lot of push toward mandatory reporting of adverse events. The administration at the time in Washington really didn't want mandatory reporting, so they came up with this voluntary system as kind of a compromise to gather information, and with the idea that because people can report more than just mandatory fields, that we might actually gather better information. And we also hope to reduce healthcare costs, because by reducing error and reducing harm, we can reduce that cost in the system. So the PSO can aggregate data from many providers. We have a system where the providers that we work with send us data on their events, their near misses, and their safety concerns. We can get that, or any PSO can, from a number of participating organizations. And because we see information from a number of organizations, we can identify patterns more easily. For example, we may see 5 occurrences where the agencies involved would see 1 and might think it was kind of a one-off thing, whereas we are in a better position to say that, excuse me, my computer just decided to fuzz out on me. We will be in a better position to, just a second here. We're going to be in a better position to aggregate it, essentially. And so Okay. We can work together with other providers in a confidential and shared space in order to share and learn how to prevent mistakes. And then our participating providers are assured that their safety work won't be used against them, which we find is a very important thing, so that they'll be more robust and they'll be more willing to share it. Next slide. So how does the PSO work for you? What does it look like if you're doing PSO work? On the left-hand side, you can see a list of actions that you're probably taking now, things that you're probably doing. So you may be doing focused trip reviews. You may be doing investigations of incidents. All of those things, the work that you're doing now, is stuff that can arguably be protected. Case reviews with your quality department or your quality manager or your medical directors and your committee meetings are all things that you're doing anyway. You may want to increase the amount of them. You may want to do more. But how do you feel about the information that's coming out of those? The documents that you might be producing could be supervisor notes about your trip reviews. Your medical director may have case notes or recommendations. You have meeting minutes, investigation notes, emails, all kinds of stuff that comes out of these processes, and you have to be concerned about where that information is going to go. Next slide. Okay, so a PSES is kind of the key concept in a PSO arrangement. As a participant in a PSO, you get to define your own patient safety evaluation system. And we think of this as the overarching umbrella over all of your patient safety and quality improvement work. So your PSES is kind of a space that you define that includes as much of that work as you want to include. And the work that goes on inside your PSES is privileged and confidential under the Act. Next slide. So what you develop inside your PSES that you decide you want to protect is called patient safety work product. That's another term of art under the law. And we've got a list here of the information that can be included in that. It doesn't have to be all this, but this is all potentially includable. So all of this stuff can be protected work product under the statute. Next slide. And so you can kind of see how we have the quality improvement umbrella over all of that work, all of those documents. And by defining them inside your PSES, then you get the legal protections for that work. Now, the law has a few things in it that absolutely can't be protected, and those basically boil down to basic business documents or information that you have to use externally for other purposes. The biggest one is the patient's medical record. So anything that's in the medical record can't be protected. Billing information is another example. Any other original patient or provider record. So if you happen to get a copy of some documents from the hospital when you drop somebody off, that's part of your normal business activity, and you can't protect that. You also can't protect the staff's knowledge of an incident. So if you have an adverse event and you report it and you want to include your investigation in the PSES, others can still access the memories and the knowledge of the staff that was involved in the event. They can't access their memories and knowledge of what happened inside the PSES afterwards, but they can talk to them about, you know, if it's a medication event, what was your involvement, what did you do, what did you know, what's your policy, those kinds of things. And you can't protect information that's outside of your PSES. So again, you define your own PSES. You get to decide what's in and out. But if it's outside, for the most part, you're not going to be able to protect it. And then you can't protect the material that reflects the actual changes that you've made. So if you have an adverse event and you do work within your patient safety evaluation system to analyze what happened, what can we do to prevent it, and you design a new policy, you come up with a new plan, you get a new provider of services or a new materials provider because you're not happy with the old one, those actual changes that you made can't be protected because they've actually become part of your ongoing practice. Next slide. And I think it kicks back to Lee.
So thanks, Kathy. I think that was a great summary, and we'll pause at the end of the presentation. So if anybody has questions for Kathy, we'd be happy to take those, and likewise, we'll have our emails available, so if you'd like more specific information about the law and PSOs. So as Kathy talked about, we collect data and information from our participants, and this is a voluntary process. And so we looked for high-risk areas in our profession, and as you can imagine, we have a number of those. And what we did is we started with 7 of the most common areas. And we have actually a data committee that works and helps us with setting up these categories and areas. And as you can see, they center around high-risk areas in our patient care. Airway events, we collect data around esophageal intubations and events that might relate to anything to do with airway management. Likewise, we have an interest in ambulance crashes, and so we collect information around those. Equipment and device issues, whether it's a device that fails or doesn't work, or something that might show up missing on the scene. That's important information, especially as we're looking for those trends, and we're able to do some analysis around that. And we'll share some examples with you in a few minutes around some of the areas that we've identified. So also medication errors, and then we have a category or a bucket that we call other. And in this bucket, we can collect anything from dispatch errors that might have delayed the response of an ambulance. Maybe they went to the wrong location. Also, we collect data around stretcher events, and also STEMI and stroke quality indicators. And just here in June, we started to better understand our behavioral health encounters, and our data committee wanted to understand what was happening specifically on behavioral health encounters, whether it was an emergent situation or was this an interfacility transfer. And I've got a slide here in just a minute that'll talk a little bit more about that. So how do we accumulate this data? How do we collect this data and information? Well, we have a online platform that is secure, and it is a portal where our participants can log in and then enter these events. And so it is a very simple process. There's skip logic built into it, so it's a matter of clicking a few boxes and then also being able to elaborate a little bit further in some free text areas. And as Kathy mentioned, we work through the Agency for Health Research and Quality. And what ARC did was develop what's called common data formats. And these common data formats were really built around patient safety in what we might see in the hospital setting. And so our data committee went to work about 4.5 years ago and started developing these common data formats specific to our profession in EMS. So they'll match up and align with both worlds, and so we're able to report this information on in a consistent way to the Agency for Health Research and Quality. And so what I'm sharing here is just a breakout of those categories that I just showed you, and kind of how they fall out and what's being reported to the Center for Patient Safety. So this is a diagram of some aggregated data just to give you an idea of what's being reported and what it looks like. The next slide here breaks it out, I think, in terms that helps us understand that, you know what, there really is harm that's happening out there. And so this is some data that shares with you that, you know, there's deaths occurring, unfortunately, from our care, and while these patients are under our watch, so to speak. And again, we're looking for patterns and trends in areas where we can take this information back to our participants and say, hey, this is what we're seeing, this is what happened, this is what's happening. And our job isn't to be judgmental about the care that's being provided. We would rather be able to identify these areas and then guide our participants towards implementing safer systems, as well as better safety behaviors to mitigate and to prevent the future occurrence of events. And so let me go back a slide here. This is the harm level diagram, and just looking at it in a different way. And even though it says no harm at 52.7%, that doesn't necessarily mean an event didn't occur. What this might be referring to is what we call a near-miss event, where something happened during the call, but it just didn't reach the patient. Perhaps it was somebody reaching into the drug cabinet or the drug bag and grabbing a box of epinephrine, thinking it was Narcan or glucose, and maybe they opened that box of medication and they got it ready to be administered, but maybe they caught it at the last minute. And so what we want to understand is, why did that happen? And you know, thank goodness it didn't reach the patient, but you know, what was the process or the behavior that led up to that, and how can we put into place a better system so that doesn't happen to somebody else? We also offer support and education in a number of different ways. We are strong proponents of just culture training. Kathy and I are both certified just culture trainers, as well as we work with other just culture trainers here in Missouri to bring this education out to our EMS professionals, and we'll talk a little bit more about that in just a second. But we also share newsletters that have lessons learned in it, as well as what we're seeing in some of our data. This year, we're also hosting a number of free webinars around patient safety and quality, helping to support organizations to understand what quality is, and maybe how to start and support their quality program in their organization. And likewise, what risk is and how to manage that. We also do what's called PSO alerts and safety watches. And these are opportunities where we can look at that data and look at it in a broad way for those patterns and trends, and then share that information out with you. And so one example of a safety alert we did last year was around two medications that were being inadvertently mixed up for a number of different reasons. And those were morphine and midazolam. And what we saw in some pretty simple analysis were that these two medications come packaged in a very similar way. The labeling on these medications are very similar. The names of them are similar. And since they're controlled substances, they're often locked together. And so we kind of have a system issue there. And in a time compression situation, when paramedics might be in a hurry, they might reach in and grab the wrong medication, and perhaps there was no timeout or a cross-check done, and the medication reached the patient. And so through our analysis and reaching out to our providers, we shared with them some ways that they could look at, improving that system, maybe labeling those medications in a different way or separating them or having a better system, and also implementing a cross-check or a timeout or a checklist before a medication is administered. And we've also had some other safety watches recently around some cricothyrotomies and a number of stretcher-related events and innovation in care that's taking place out there. And as Kathy shared with you, this work really started in Missouri about 4.5 years ago, where our providers in our state did not have any protections around that quality work that they were doing to improve their organizations, and they were concerned about that work being used against them, and likewise not having that way to share information and learn from each other. And so they came to the center. They knew that we were working with hospitals and health systems, and we started this PSO work here in Missouri. And what started as something in our state has really grown on a national level. And as our profession starts to look at new standards and measures and indicators and greater scrutiny, we feel that it's certainly important we keep doing that quality work, but likewise, I think people are understanding the value of protecting that work, and also ways that we can share knowledge around these events. And if there's one thing I would like to be clear is that the federal law isn't a deflector shield or a way to hide things. It's really built, as Kathy mentioned, a way that we can improve what we're doing as a profession. And also there's a business case behind this as we look to prevent the occurrence of these events and save healthcare dollars that are valuable to everybody. Two pilot programs I just wanted to share with you that we have underway, one of which is on the left side of your screen. It's a frontline reporting tool, and we're hesitant to call it an anonymous reporting tool because in today's world of technology, there's really nothing that's anonymous. But we wanted to have a tool where frontline providers could share information around adverse events and near misses and unsafe conditions. And so this is a very simple reporting tool that lives on an organization's intranet system or maybe on their mobile devices, where they can click an icon, open that up, enter the event information, and then that event information goes up to the leadership in the organization, where they can do their analysis and understand what's happening out on the street. And it's important also to understand that we want this tool to be used in the right way, in a non-punitive way that we'll talk about in just a minute. And so, so far, the experiences that we've had with the tool being out there with the pilot program has been received very well and with some great positive feedback. There's just a lot of things that happen out in the trucks, as you know. It's kind of the Vegas syndrome. What happens in the ambulance stays in the ambulance sometimes, and things really just don't bubble up in an organization. And likewise, there's a lot of things we don't hear about, whether it's a transfer of care and between our patient handoffs. And so we hope to capture more of that information and find areas of risk where we can be proactive. The other pilot program we have underway, as I mentioned before, is around behavioral health. So we can understand more clearly what's happening with these calls, whether it's a provider safety issue or a patient safety issue, as well as what's happening on inter-facility calls. And we wanted to have a safe place where this information could be collected. And oftentimes, this patient population presents unique dynamics. We might encounter patients that are trying to elope or jump from ambulances, or there might be other concerns. So we wanted this information to be collected in a safe way and in a safe place. And so the PSO was really a great way to do this. So as we want to improve the safety in our organizations and reduce the risk of harm reaching our patients, it's important and probably imperative to say that we want to develop a culture of safety in our organizations. And so as I mentioned, we support Just Culture, and there's a number of different programs that are out there and available, everything from team steps to CUSP to something called WINGS that might be a crew resource management type of program. We like Just Culture because there's an EMS specific component to it. And what Just Culture brings is an opportunity to develop a shared responsibility into an organization where you're not working in a punitive culture where people are getting hit over the head for making a mistake, but at the same time, it's just not a free, no blame culture where anything goes. But it is really about developing that culture where people feel free to exercise those safety behaviors and come forward and say, hey, you know what, I had a near miss on this call, or I made a mistake and I don't want it to happen again. And so it offers a number of different tools to the management team as well as to the providers to develop this this approach in an organization. And so I think an important part of what we want to accomplish, especially since we work in such a high consequence industry. And if we look at other industries that work in a high consequence fields like aviation or the nuclear field or shipping and mining, they've all moved to a culture where people are free to talk and interact, because it's really hard to fix a problem if nobody's going to come forward and talk about it. It's kind of like working in the dark. And so what Just Culture teaches us is a way to really look at what's happening in an organization, but at the same time also offer us the tools to work and to address these different areas. And this is probably my favorite slide, and I think because it helps us to look at the system designs of an organization, whether we have a system failure or a process that's not working, but then also the behavioral choices and the decisions that we make that drives these adverse events or human errors. And Kathy, feel free to jump in here if I miss anything. It's also, you know, having this foundational approach where we're working together as an organization to address these areas. Kathy, is there anything you'd like to add that I might have missed on Just Culture?
No, I think you've done just fine.
So if you are familiar with Just Culture, that's great. You're really ahead of the curve. If you've not heard of Just Culture, or maybe you've, maybe had a little bit of exposure to it, we would encourage you to attend a one-day manager's class and to learn more about it and how it might work in your organization. And if you'd like more information about Just Culture, feel free to reach out to the center and we could help you get that information. So kind of to summarize what's in it for you and your system by participating and working with a PSO, as Kathy talked about, it's that federal level of confidentiality that's not found in many states, and also kind of plug some of those gaps in areas. So even though if you might have some protections in your state, it's kind of that overarching umbrella to fill in those areas. It also allows you to utilize the platforms that we have that really offer some robust analytic capabilities to run reports and to do some risk management or even some quality work with our platform. We're here to help you if you want the assistance in structuring your quality improvement process. We are not here to tell you to do it one way or the other. but we are available to offer any assistance. And likewise, also there's some unique opportunities by participating with the PSO when it comes to having some protected spaces for discussions and analysis. And one example of that is what we call safe tables. And we do this every year at our patient safety conference. And we'll be doing that coming up in October at our conference. And what the Safe Tables offers is an opportunity for EMS providers and leaders to come into a safe environment where everybody signs a confidentiality agreement, and we sit down and we present some de-identified cases. And we look at these cases not to judge the crews or the organizations or what happened on these calls per se, but to use a defect tool and kind of use some science and work through these events to see, you know, what happened, why did it happen, how can we work to prevent this from occurring in our own organizations, and how can we and what can we take back home and implement in our organizations. And so last year we did this at our EMS Patient Safety Conference. It was received very well, and we'll be doing this again this year at the conference. Likewise, we also have a number of different toolkits and other resources that support our participants in learning about patient safety. Where this work really begins is a desire and a willingness from an organization. And we meet a lot of different organizations, some that are very small, some that are national organizations. Whether ground or air, I think it's really the willingness to say that we want to start this patient safety journey. And it's kind of like a bell curve. And out front in the bell curve, you have the early innovators, the early adopters, the thought leaders that say, you know what, we want to take this work on, and it's important to our organization and to our community. And kind of on the top of that bell curve are the people that are just watching and waiting, and then behind are the people that, you know, will make change when it's required or regulated. But the work really begins with a contract, and this is a requirement through the law that says that you want to participate with a PSO, and then we will work with our participants to make sure that their quality processes are defined in that patient safety evaluation system that Kathy described. And then we develop a policy that really outlines that work and that patient safety work product. And we've done this several hundred times now, and we have a streamlined process, and it's, I would say, a process that can be done. I think in the shortest period of time we've ever done it is maybe 72 hours, and it's really up to the organization and how fast they want to go. And then we work with our participants around any additional education and training, utilizing the platform, and then offering any assistance that might be required. And so, in summary, I'd just like to kind of share with you what some of our participants have found to be the return on the investment. And, you know, it's really about benefiting the organization and what you're doing with your patients. And, you know, certainly the protections and confidentiality points are important, but also, you know, being proactive and finding those opportunities where we can fix things and be out in front of things before they occur and move our profession ahead. So with that, that concludes our presentation, and we'd be happy to pause here and answer any questions or and happy to hear any comments that you might have. And so I'll just be quiet here and see if Dr. Antevi might have anything, and feel free to ask any questions.
Okay, awesome. Thank you so much, Lee and Kathy. Just for everyone on the webinar, if you'd like to ask a question, just click on the question icon, the little hand raising, and I'll unmute you. So while we wait for that to happen, I just wanted to make a few comments. First of all, this for me is, you know, I think that there's no other industry, no better industry for this type of process to be involved with than EMS, because unlike in the hospital where there's multiple people watching and any certain thing happen, whether it be an error or not, in EMS it's really you have 2 or 3 people and things happen kind of inside this encased vehicle. And I see that the Chief Downey's on the line too. We work closely together, and she's the EMS chief at the Davie Fire Rescue. And what I often find, and I'm sure she'll agree, is that when we have our medical director meeting and we're face to face, boy, all these things start coming, towards us. And this happened and this happened, and I kind of want to say, well, how come we don't know about this, or how come this happened months ago and now I'm only finding out about it? And it turns out that the culture, and it may be the culture of retribution or being fearful, like you had mentioned. And I think that if there was a mechanism where there was, that it wasn't a punitive mechanism and people could feel comfortable and the culture did change in that direction of really a culture of patient safety, then I think the behaviors would change, and then we could make the system better. So that's comment number one. And then the other comment is we're very quick oftentimes to say if the mistake happened, it must have been the paramedic's fault. But I disagree, and that slide that you said was your favorite slide, I really like that slide too, because maybe it is a systems problem. Maybe we aren't providing the best system for our paramedics to work within. And if we are able to analyze that on not just an agency by agency level, but across multiple agencies, then I think that's the home run is right there. So Joe Nelson, who's our state EMS medical director, is asking a question. Joe, I'm going to try and just get you unmuted here. One second. Let me see if I can do this. Okay, let's see. I think Joe, you have to type in an audio pin, which I just sent to you in order to be unmuted, which is #80#. Joe, if you want to do that, but let me read the question in the meantime that Joe wrote. Hold on. This is a great question. So Joe writes, is there some way that we could cover the entire state of Florida? That would be amazing if that was the case. So I'll let you go ahead and talk about that one first.
So that is a great question. And as we shared with everyone, this work really began in Missouri, and the Missouri Ambulance Association were leaders, as well as our state EMS medical director at the time, who saw the value of this in offering these protections through the PSO, as well as how we can improve the care that we provide. And certainly, I think there would be an opportunity for us to talk offline on some different strategies or ideas or concepts on how we might be able to work towards something like this in Florida.
Right, that would be amazing. And Joe followed up, like he said, for example, if the PSO dealt directly with, or if the center dealt directly with the Department of Health, perhaps, I think that would be the way to do it. And I think that mechanism here in Florida would be best because, to be quite honest, I'll give you Broward County, for example. There's numerous departments, over 20, and each of them run like their own independent business, if you will. And for example, if we only have 1 or 2 events in one agency, but you multiply that by the 20 plus agencies, all of a sudden you have really important, and you have data that's really usable. And so I don't see each individual agency kind of going and getting this done in a very kind of short manner. I think that, like Joe said, if it's a statewide initiative, and we as EMS leaders can just say, yes, of course we'd like to be involved with that, then I think it'd be really a home run.
This is Kathy, and I have to be the Debbie Downer here. The way the law works, we have to have an agreement with the providers that are working with us. And we've analyzed a number of different constructs and scenarios in EMS, because it's like if you've seen one in EMS, you've seen one. And there are ways to get broad participation and a really broad function, but it really involves, to be truly effective at it, having all of the providers contract with the PSO, because that is where the protection comes from under the statute.
Right. I think that would ultimately happen on an individual basis once we get kind of the participation, if you will, from the state level. And if the state level endorses this participation or even pays for it, or whatever the cost would be, if it happened through the department. And again, I may be speaking for Joe here, but I'm trying to get him off mute, but I don't think I can do that. And so that, I think that's the concept. I mean, yes, every individual agency would end up contracting, by themselves, but through an initiative that was taken over by the state.
Yeah, and we have had that, and it does lead to a high proportion of involvement. Fortunately or unfortunately, you still have to have some initiative and some willingness to participate by the agencies. So simply having folks at that central level active and involved in it isn't going to get you where you want to go.
Right.
And I just want to be real upfront about that, because we've had some folks that had a lot of energy injected into getting something set up, and you've got to have the grassroots support for that as well.
Right, and I think it goes to that bell curve that Lee was talking about, because there are those people who just will wait until it's mandated, until they participate. So Joe writes in here that would you be able to present this? We have state meetings coming up in January. And would there be, is there the ability to have a presentation where we have really all the leadership, medical directors, EMS leadership, in other words, all the Department of Health folks are there as well. Would you be able to do that?
Sure, I think that we would love that opportunity to share more information and to answer any questions. So yeah, we would love that opportunity.
Okay, great. Yeah, because regarding the grassroots, like Kathy just mentioned, once you're in front of it, I think the last meeting was pretty well attended. There must have been at least 50 some odd people in the room for the medical directors meeting, and they always allowed about an hour or so on the front end for presentations. So I think that's kind of a great place to start. Do you have any kind of data for us? And I know that this is probably not enough time on this presentation, but can you kind of show us what other agencies are providing to the PSO, and what type of outcomes you're providing to them as far as the return for, let's say, the administrators to say, hey, we're actually making a difference here?
That's a good question. It's a common question that's posed. Since we share information in a de-identified way, we really can't say where it's coming from. We need to follow the law and make sure that information is protected. I think that we're still a little bit early into PSOs to really say or to be able to measure a specific impact on what we're doing. Certainly that being said, an organization might be able to identify some specific areas where there were lessons learned, or where we might have shared one of those watches or alerts or something they learned at one of our events, or through the education that might have prevented or mitigated the occurrence of something in their organization. So does that kind of help answer the question?
Yeah. I understand. And then the other question I have, and again, I'm waiting for other people to chime in, but the other question I have is regarding one of the slides that had about behavioral health. And I'm just wondering, our last webinar was Chief Zigowitz from Colorado, who talked about paramedic suicide and so forth. And I was wondering, on that mobile application that you're piloting, was that also part of the input? Let's say a paramedic is just feeling down and feeling uncomfortable about a certain call or what have you. Is that something that is included in that pilot application?
Well, we haven't targeted that specifically at provider behavioral health issues. We know that there in the industry right now is a lot of concern around mental health within our providers, and so that might be a different category altogether that we might want to explore in the future. Currently, our behavioral health piece is geared more towards the encounters that we're having with those specific patient populations. However, correct me if I'm wrong, Kathy, anything can be reported to the PSO, but again, the focus of the PSO is around patient safety and how we can improve the quality of that. And there maybe might be some linkage to say that if a provider was having some issues or concerns, that might somehow link to patient care.
Yeah, and we do have resources on the provider side as well. The center is actually co-sponsoring a Train the Trainer workshop in September with folks from the University of Missouri who have a very active program around what they call second victims, which are the healthcare providers that are involved when there is a medical error or an adverse event. So there's a lot of work going on around that, and the center is involved in it. But the PSO reporting function was really designed kind of through the statute to focus on patient issues. However, in our work, we recognize that that also includes the providers. It just may not be inside that PSO box.
Right, right. It seems like the infrastructure is there to have a culture of, maybe like a little anonymity and type
Right.
of thing. So yeah, I mean,
Right.
they're just a thought, because I think that
Right.
it's kind of an important topic.
And Kathy, thank you for reminding me. Our next EMS webinar is coming up here in September, and Dr. Antevia, I'd be happy to forward the information over to you. It's a free webinar that we're doing that explains more about the second victim experience. And as myself being a provider for many years, I know people have their own stories. When an event occurs, it impacts people in different ways. We have a great sense of pride in what we do as providers, and oftentimes we're not really feeling fully free to come forward and talk to people when we make a mistake. And so the second victim experience is really there to support the provider and other people that were involved on a call when something went wrong, or perhaps a provider made a mistake. And it's important also, as we look at just culture, to realize that we're human. We're going to make mistakes, and we can't rely strictly on personal performance. We need to really have good systems in place that catch us when we make a mistake. And we learned that from aviation, and in our profession, EMS, was really driven out of this world of we want to rush to the scene and make a difference, and we can make a difference. And sometimes we need to take a step back and realize we're human. We're going to make a mistake sometimes, some place in our career. And even though that may not be something reckless, we're still prone to these human errors. And so I think being able to support our providers is something really important. And so you might find this second victim program of interest.
Excellent. Well, I tell you what, I'll be the first to stand up and raise my hand and say that I've made mistakes, and I've matured in a way of kind of understanding how to deal with them, how to speak to families about them. And now I know that I think everyone on the line here probably feels the same way, that we have to provide the leadership for all of our field providers in order to help them understand that there is a right way of doing things, that we don't expect them to be perfect, and really to try and help our organizations, which is really the reason that we had you guys on the webinar today. So we're right up at 3 o'clock here. I don't see any other questions coming on, but Lee and Kathy, thank you so much for your time today and for really educating us. And hopefully we can, with the right people here on the webinar today, and we'll be forwarding this out to our other leadership who weren't able to make it, hopefully we can start to talk about this as a Florida item that we can start to move forward to. Thank you, guys.
Great. Thank you, Dr. Antevi, and thank you, everybody that joined us today.
Okay, bye-bye.
Bye now.